Good morning, everyone. I am Dr. Ruchira Misra. I am a senior consultant in the Department of Pediatric Hematology, Oncology, and Bone Marrow Transplants at SRCC Children's Hospital. And today, on February 15th, we are gathered to celebrate the International Childhood Cancer Day. International Childhood Cancer Day is basically an international collaboration amongst all the pediatric oncologists of the world, and this is to give an awareness about childhood cancer, support the parents and the families of children who have childhood cancer, support the survivors of childhood cancer, and also to create a general awareness about the curability of cancer. I have with me today Dr. Purna Kurkure, who's the head and the chairman of the Collegium of Oncology at Narayan Health. She also heads the Department of Pediatric Hematology, Oncology, and Bone Marrow Transplant at SRCC Children's Hospital, and has been a big stalwart for all us pediatric oncologists. One of the few people who's actually started pediatric oncology in India. I have also with me Dr. Sujata Mushrif, who's a consultant and has a special interest in pediatric neuro-oncology, and she is also part of the team which comprises of the PHO unit at SRCC. So we are planning to hold this awareness campaign by asking a few common questions that we are asked when we deal with children with cancers. My first question to ma'am would be, ma'am, what exactly is pediatric oncology?
Oncology as such, that word is coined around the word oncos means tumor. So it is a branch of medicine which deals with tumors, particularly malignant tumors. So oncology deals with all aspects of cancer, and pediatric oncology is a specialized branch which deals with children with cancer.
So, most of us are often asked, do children actually get cancer, and why is pediatric oncology a field? So, Sujata, wouldn't you come across this question that do children get cancer as well?
Yes, children actually do get cancer. It can be as early as when they're just born to when they're in their teenage years to just entering their adulthood, any time of the period. It's much less than in adults, but it definitely is a common thing.
How common is it?
So, in the US based registries, if you look at the United States registries, it's about 14.9 cases per 100,000. In the Indian state registries, we have seen it about 13 to 15, and in some states as high as 23%. If you look at the hospital based registries of the major regional cancer centers, it can be about 5% of the total cancer patients that are registered every year, which includes the adults and pediatrics together. Just to put a number to this percentage, it is about 40 to 50,000 new cases in the country. And if you look at worldwide, it is about 150 to 160,000 new cases each year. So we form a major portion of that global burden of cancer. However, when we actually look at the number of patients who get registered at various centers, it is probably only one third to one fourth of those 40,000 cases that are expected to for the registry.
Okay. So, what you mean to say is, though it's an estimated amount to be big, but the numbers actually coming to the hospital is much smaller.
Yes.
So, we believe that there's a World WHO collaboration that has started. So it's the WHO initiative against global cancer, and the intention is that we have to improve our survivals to at least 60% by the year 2030. So that is how we are going to become strong, and that is how we're going to create this awareness and try and deal with childhood cancer. So yes, pediatric cancers is an entity. In fact, it's such a big entity that we have pediatric oncology as a super specialization field. Okay. And when we talk about pediatric oncology or pediatric cancers, we are not just talking about blood cancers, because a lot of people believe that it is only blood cancers which are commonly seen in children. Yes, blood cancers are the maximum number, or at least half of what we see in our day-to-day practice, but also there are solid tumors, so cancers that are originating from the kidney, from the liver, from your muscles, from your eyes, different areas that can come up. Uh, a lot of these times, and that is about 50% of the work that we do dealing with what we call solid tumors as well. So, ma'am, how are pediatric cancers different from adult cancers?
So I always like to quote this sentence that child is not a miniature adult. So we don't get the replica of what the adults face. In adult cancer, it is mainly the environmental factors and lifestyle which really matters a lot in deciding the predisposition to cancer. For example, we all know that if you have a smoking or tobacco in any form, somebody is more prone to get cancer, obesity, and so on and so forth. But the lifestyle factor is not yet operational in the children, you would consider that all these factors are not there. So, why so? Because the childhood cancers are basically arising not from the organs but from various tissues at risk. And basically, this carcinogenesis or cancer formation occurs by certain abnormalities or certain changes, mechanisms which happen at a gene level, so that there is a one hit which occurs during the utero while child is being formed, and whenever there is another hit outside the uterus during the childhood, that you can get the cancer. So these cancers are mainly associated with the various tissues which are very versatile and under the formation. That's how you will see the childhood cancers with more uh, potent, rapidly dividing cells like hematopoietic cells, and that's how you have a large number of leukemias and lymphomas. Then you have a germ cell tumor, muscles, and the bones, which are growing tissues. And also, the child undergoes the brain development post birth, almost 20 to 30%. So you have a largest number of brain tumor as one of the solid tumor. So all this is a reflection of some changes which are already there, and during the further development, during the childhood, you can have some mechanism of second hit leading to cancer. So this is the main difference, that it is not organ specific; it is more tissue specific. So in an adult, you will have the cancer of the stomach, cancer of the uterus, cancer of the ovaries, cancer of the breast, head and neck cancers, and these are all the organs which are continuously exposed to the outside insults, and over a period of time, it can metamorphose into cancer.
One of the biggest differences that I like to quote is that pediatric cancers are curable. Whereas with adult cancers, you generally talk about, in most cases, a progression free survival.
Why? Because the childhood cancers, they are very rapidly dividing, and that is why most of the treatments that we give, that is chemotherapy, radiotherapy, they are very effective. While in adults, it is a slow progression, and they are very heterogeneous, and that is why the some of the very important tools are not as effective as they are in children. And the biggest difference is also the prevention. Many parents, they ask, could we have prevented this cancer? But there is no role for prevention much in children, because it is not dependent on the environmental factors as it is in the adults.
So a lot of parents also ask us what caused this cancer, and generally what we tell them is that we do not know exactly what was the insult that led to the cancer formation. Although there are a number of reasons why pediatric cancers happen. One of them, which ma'am already alluded to, is a two-hit hypothesis or a two-hit mechanism that we talk about. That there is something defective in the genes of the child, and then a second insult happens, because of which this leads to the formation of cancer cells.
But this is not equivalent of inheritance.
Yes.
Like many people have this misconception that if the one child is affected, the next child can also get affected. So it is not equivalent of inheritance. That runs in the family, except for very few cancers.
Very few cancers are hereditary.
Typically, the retinoblastoma, the cancer of the eye, There are very few which are inherited cancers, but it is a defective embryogenesis and further development which is causing cancer.
Some of the other insults that could happen maybe because of insecticides or pesticide exposures or infections that could have happened, whether be the infections in utero while the baby was in the mother's womb, or be it as a young child, those infections can again make this change happen, which then leads to the development of cancer cells. But how does a parent pick up that their child has cancer? So, what are the common signs and symptoms of cancer, Sujata?
So, the unfortunate part of the pickup is usually the parent faces that how did we not think it was cancer, because most of the signs and symptoms are of the general pediatric kind. So, it might be a fever, might be a small cough or a cold or a bruise like thing for which they take to the pediatrician and say a complete blood count is done and it shows that the counts are very low, blood counts are low, and could be a diagnosis of a leukemia happening at that time. Or say a parent is just bathing a child and most commonly feels a lump in the abdomen, and that could be a tumor of the kidney or a tumor of the liver. So oftentimes the child otherwise absolutely looks fine and they're very agile. So unless they really don't feel well, they don't stop playing or doing the fun things they like to. However, there are certain red flag signs that we always say that should alert a parent or a pediatrician or a doctor to look for cancer, to have a suspicion for cancer. Uh, Ongoing fever, which is not getting better, where a cause is not known, could be a cancer related fever. Um, a pain in the bone or a pain which avoids the child from playing, what we call a thing which causes the child to limp, is a possible cause of or a symptom of cancer, because they don't necessarily make it up or stop playing because of just a little pain. That should be seen with carefully evaluated. A headache which wakes up the child from sleep, or an early morning headache followed by vomiting, could be a heralding sign for a brain tumor. Now, mind you, not all these signs always mean that your child has cancer, because these are the common things you can see in any child who has any common illness. But if something goes on for a while, then those should alert you and a further evaluation is necessary. Would you want to add something else?
No, same thing. It is the duration and the repetition of the symptoms over a period of at least 3 weeks and above, which is the point of concern. The commonest other presentation is the lymph node enlargement, which get treated very commonly as tuberculosis or TB in our country. But okay, even if you have not done the biopsy, at least 2 to 3 weeks period there is no improvement, then one should become alert and take the next steps and investigate. In short, no child should get empirically treated beyond 2 to 3 weeks for any symptoms which are persistent and repetitive.
Completely agree. One more thing I didn't mention was the retinoblastoma or cancer of the eye, which can often present as a simple white looking eyeball or white looking eye, which needs to be very carefully evaluated. In fact, we urge all pediatricians to actually screen with a simple test that is done or called a red reflex test. So you can pick this up earlier and the vision can be saved if picked up earlier.
Sujata, in today's time when everybody is clicking the photographs, this is a very which can be picked up very commonly by parents. But we have to give credence to what parents have observed and follow it up. Exactly. That is very, very important. Many parents say that they observed something while they were clicking the picture, but so no importance was given to that observation.
So your photo will have a white reflex instead of the red eyes that you see on a regular photo. Your camera or your phone photo will show white dots in the eyes instead of a red dot, and that should alert anybody, and the child should be evaluated. And of most importance is when a parent says something is not right with my child, you should take it as a gut feeling and investigate further, because the parent knows the child the best.
So treatment always involves the parent, and a better informed and an involved parent always gives us better outcomes. So, if you have any questions, parents, please feel free to ask these questions. We will be happy to answer them whenever as soon as we get these questions. So, use this opportunity to ask us questions as well.
And I completely agree with Ruchira with you on that, Dr. Ruchira, because it's not the education of the parent that matters in terms of how good a care they can provide to their child. We have parents of all economic background, all educational background, as long as they are
Involved.
explained and they're explained what needs to be looked for and what needs to be done at what time in a broken down simple language. Even the most illiterate parents take beautiful care of their children.
Now, treatment for cancer is a big issue that people often talk to us about. What I will say is that treatment is, in our language, we call it a multimodality treatment. So, we involve a lot of people when we're giving care to the child, and it's not just the child, it's the child and the family that need care. When we're looking at just the treatment of the cancer itself, it is a multimodality in the sense that the child may need chemotherapy, may need radiation therapy, may need surgery, may need either one of these three, may need all of these three, or maybe a combination of these as well. But also, the child will need help with dietitians, will need help with good nurses who can play with them, at the same time administer their medications, will need the help of a good psychologist who can understand their needs while they're in the hospital. And this is especially important if we get children who are adolescents, young adults who come in, because their needs are very different from those of child. So treatment for cancer is a very big multimodality treatment. Lots of people get involved in it, and most importantly, the parents. The parents have to be involved in the care of their children, so they need to know exactly what's happening, and whether they have any suggestions as to how to better take care of their child as well is always welcome with us. But a lot of people talk about treatment for cancer being very expensive. How do you deal with that, Sujata?
Before we go on to the expensive, I will like to point out this multimodality approach. And now pediatric oncology has matured to a level that we exactly know that in which chronology how to treat. And this has to be laid out upfront. Yes. Based on certain risk stratification that we use. The risk is, if child has got certain risk, that risk means risk of relapse. So if the child has a high risk, means it is a high risk for relapse, and that is why you need to give more treatment, more aggressive treatment, because no cancer, if it is curable, is incurable just because the experts say that if treated properly, all the cancers can be curable in this age group. But why do we fail? And there has been lot of research on that, and that is why this risk stratification has become a very important issue for which we do lot of investigation. But that is worth an investment to come to a correct risk stratification, to give less treatment to those who don't deserve excess treatment, means higher treatment, and give higher treatment to those who have a higher risk for relapse. Yeah. So this is very important first step in the treatment of childhood cancer.
So, coming on to the expense and the cost of treatment, so there is various stages in the diagnosis as well as treatment and follow-up of cancer. So, the diagnostic evaluations often can run to a higher side of cost and can itself be a difficult time for the family to take care of.
Basically, because we want not only a diagnosis,
as you mentioned
but
about the risk
stratification.
So, and which she properly, very beautifully alluded that you need to have a good risk stratification to know what armaments to use, what medications to use, what exactly needs to be done. So that is a very important part. It's not that we can just do a half-hearted job and get a good result when it comes to that.
Parents come with a like there is a common fear, or they step into the hospital with the probable diagnosis of cancer, and they think it is an emergency, and they want treatment immediately. Right. Which is also a myth, because cancer, besides certain situations, we don't have to treat immediately without a proper diagnostic evaluation. So that is another myth which we should demystify, that cancer is never an emergency. It is the cancer related other medical problems which we have to tackle first, have a proper diagnostic evaluation, and then start.
Definitely. So, we have to be patient enough to get all the workup done and know how big our problem is before we actually start the treatment. Treatment includes multimodality care, as we spoke about. Many specialists are included in that. Many different treatment modalities are included, which add to the cost of the care of the entire thing. And a major portion of cancer care is also the supportive care which we need to give with the medications which we use, or chemotherapy or radiation therapy that we use to cure it. And that adds to the cost, which the supportive care would be antibiotics, sometimes need critical care or ICU admissions, because they are very much at a higher risk of infections because of their immune mechanisms being suppressed because of the medications we use. They often need blood product support, which add to the cost. And on a collateral also, because a child needs constant care, if both parents were working, one parent can't work, or they can be dissociated from a rural part or interior part when they come to a bigger city or a bigger center to get treated. So there is economic losses on both sides in terms of the actual treatment as well as the loss of pay. If they move to say Mumbai for treatment, then they need to figure out where they're going to stay, how are they going to manage their daily living costs and that.
So
So
this
it's
is
a very huge
all
amount.
put together as a out of pocket expense, and it has been shown that they run hand in hand, almost as much as the treatment would cost.
The out of
The
pocket
out of
expenses.
pocket expense
Expenses are
also
also
goes hand in hand with that. So we have to have a societal support to take care of this, because this is a societal aspect. How to support a
Yes.
family who is undergoing this very difficult journey. We have to hold their hands and be with them.
Ma'am,
And I would like
Besides,
to SRCC look after its patients.
Sure. I'll come to that. I would like to appeal to the general public or general people who are looking that there is a big stigma when somebody has a cancer, and often parents don't want to tell this to their relatives, their family, because they feel they will be shunned or they will be looked upon badly. So they're also reluctant to get help from their family. So we have to come out of this. Any one of us can have cancer, and any one of us may need help, even if we are well. In the affording range when it comes to the treatment. It is a huge amount. So we urge all people to be open-minded and be aware
and
rather
communicate
than,
their
and communicate the needs rather than stigmatize such a thing. Especially because childhood cancer has as high as 90% survival in many of the these things, but definitely an overall survival of 70% in most cancers. So coming to Ruchira's question about how do we handle it at SRCC. So at SRCC, we take care of all categories of patients, by which I mean all economic backgrounds. Um, but almost 70 to 80% of our oncology patients have been supported through philanthropic trusts. And we're very grateful to them because that helps the families to complete treatment. And we are happy to say that there haven't been any treatment abandonments because of the money. And of all the patients we have treated, almost 100% have completed treatment as per the plan um, laid out.
So most of the pediatric oncology treatments are protocol driven, as we say. We have so the group, the pediatric oncology group, is already united in that sense that we have defined protocols to form.
Yes.
And again, we would urge most of the parents to ask what protocol is being followed whenever you are going out for treatment at any center, because these protocols are basically proven
Lots of
methods of
research.
research, which has shown that research works, and therefore treatments
and
work.
it is a disciplined way of treating
Treating them.
rather than treating on ad hocism.
And I mean, when you're saying that, one of the biggest improvements that I've seen in terms of survival has been pediatric oncology. Almost like a prototype in terms of doing good clinical trial research and seeing how simple changes
That is
improve
one of the
survivals.
difference. One of the difference between a pediatric and adult cancer too. That 80 to 90% of children they go on to the at least in United States, they go on to the all
Trials.
on protocols which are approved by the Pediatric Oncology group, while only 10 to 15% they are on clinical trials on adult side, because there are many ways of treating, and there are many, you can do this, many options available, and that is the biggest
And
difference, and
we
perhaps that is the reason why this
outcomes are better.
disciplined way has led to such good outcomes.
And I would urge parents to be more aware, to ask questions, to come with a book which has questions written down, even if you feel anxious in front of the doctor. Because the more you ask, the more you will understand, the better care you will take. So we always encourage that in our patients.
So, what we believe is that each child is precious, and that is why, just to say that, because they're as precious as gold. Let's put it that way. And therefore, the color for childhood cancer is gold, and that is why you see all of us dressed in gold today. It also shows the resilience of each child with cancer, because they are ready to fight their disease and come out of it and become a survivor. And all of this conversation we have been talking about is the curability of pediatric cancers. So, ma'am, my question to you is, if pediatric cancers are curable, do these children then live a normal lifespan? Do they get some problems later on? How do we look after them in these cases?
Childhood cancers are very highly curable, and across the board, you can say that 80% of children with cancer are expected to be long term survivors beyond 5 years from diagnosis, which is equivalent of cure, because there is a very little attrition of only around 5% in the ongoing period. So, if those who are surviving at 5 years from diagnosis, 95% of them would survive at 10 years and down the line. So, that is the way it is projected.
So when
And
we are talking about 5 year survivors, we don't mean that they will survive only for 5 years. What we are saying is that they survive for 5 years, and the chance that they will live their normal
non life,
lifespan is very high.
very high.
And by that you mean survive in the sense without a relapse or
So survival is disease free survival, and there are certain diseases which are not good, and there are certain which are overwhelmingly good. Simple things like Hodgkin's disease, Wilms tumor, where they are in excess of 90%.
Yeah.
And there are certain diseases which we still are battling with, like one form of leukemia, acute myeloid leukemia, and all. They are not as high as others. But overall, we can say around 70 to 80% should be curable, in the sense of living beyond 5 years disease free and well. And they have the potential of like any other child in the society, and that is why these childhood cancer survivors are a treasure for all the oncologists, because they teach you a lot, and we also have to put in a lot of efforts to see that they come on ongoing follow-ups and they are looked after. There is a transition, it's a difficult transition to say from being a patient to being a survivor, and many people, many survivors, they don't accept this transition from being patient to survivor. And most of them, I would say, if you have 100 survivors, you can divide them into one third, almost 30 to 40% will be totally normal. 30 to 40% may have a minimal problems of what therapy, late effects of therapy, what we call, and almost 30% will have a severe morbidity which needs to be tackled by everyone. It is not only the medical morbidity, but also psychosocial morbidity which goes with it. So we need to look at all the aspects very holistically and see to it that they get reintegrated into the society. And that is why this concept of late effect clinics to monitor this childhood cancer survivors has come in, because all of us are quite busy in the active OPD, seeing many sick patients, and our priorities are different, while these survivors need to be looked from a different angle, more closely, and though infrequently. So they come once a year, perhaps twice, once in 2 years, and they need to have a complete attention to all their issues, both medical and psychosocial.
So, ma'am, when survivors go back to the community after they finish treatment, we call them survivors, they are our champions, our ambassadors. But when they go to seek a job, a lot of employers refuse jobs to them, saying that because you've had cancer, you'll need to go back for repeated visits or you'll have frequent health issues. What would be your take on that?
It has been shown very clearly that it is the ignorance of the employer which really guides this decision. Otherwise, the survivors are the very faithful or a most loyal employee because they value and they remember their experience and they want to give back to society. And survivors like we have to, and that is why we have they have to advocate for themselves, and that is why we have this childhood cancer survivors support group, at least in Mumbai, which functions under the umbrella of Indian Cancer Society, called UGAM. And so many of them, on the contrary, now they come for the opportunities, employment opportunities to UGAM, to say that do you have an eligible survivor we would like to employ. So if they come together, they advocate for themselves and show that on the contrary, that platform can turn them around into a better job opportunities.
Yeah.
They are not underprivileged, like I would say, they are not under the special category as we have for many jobs. But still, by their own advocacy, they can create their own platform.
And they may have certain minor disabilities or something, but that can very well be accommodated, and their abilities can be actually used to in the job, or appropriate job can be offered to them.
But yes, as ma'am said, we need to have very good advocates for childhood cancer. We physicians are very good advocates. We love our children with cancer, we fight for it, we dream of curing cancer and everything. But we need our parents to be good advocates too, and we need our survivors to be the advocates and ambassadors. Because unless you go out and show the world that you're a survivor, nobody's going to talk about childhood cancer as well. What we really need is a good platform where we all can hold hands together and say that together we will, we can, and we will do it. So, this is where I would like to conclude on this and say that we would like all of you to support us, but create an awareness, and please, please don't shy away from coming forward to say that my child has cancer and I need help, or I need treatment, or the child needs treatment. There are multiple centers across India doing good cancer care. We would like to increase these numbers that we have, but yes, cancer care is available, and very good cancer care is available in India as well. So thank you so much for your attention today. Thank you, Dr. Purna, and thank you, Dr. Sujata, for this wonderful information that we've been able to have a talk about. Thank you all.
Thank you.